pressure, every additional stage of arterial hypertension will result in increase of myocardial infarction, stroke frequency, and death, which may be caused not only by cardiovascular reasons but also other reasons which associated with arterial hypertension. In patients with diastolic blood pressure higher than 150 millimeters, risk of stroke rises 3 times and risk of myocardial infarction rises 2.5 times as compared to normal blood pressure values. Another very interesting research of the British doctors, meta-analysis of more than 61 randomized controlled trials, and more than 1 million of patients were included in this meta-analysis. The duration, total duration of this research includes more than 12 millions and 700,000 of patient years. So one patient which took drug during 1 year. And it was shown that every increase by 10 millimeters of blood pressure results in very significant increase of myocardial infarction, stroke, and so on. And every time when you decrease blood pressure by only 10 millimeters, you decrease mortality caused by strokes by 40%, mortality caused by ischemic heart disease by 30%. So every 10 millimeters of blood pressure decrease. So it's very important. Every millimeter of blood pressure in our patient is very important in prevention of mortality. Here you may see the source of modern and contemporary information in the treatment of arterial hypertension. And additionally, every local authority, every local professional society of cardiologists or arterial hypertension society have own websites where you can find not only global documents, but additionally you may find your local documents, which may be important, which may have important modifications in comparison with the global recommendations caused by ethnic or by race peculiarities of your patient in your country, because we know these pharmacogenetic differences between Asian patients and patients who lived in Africa. So European Society of Cardiology or American Society of Cardiology published globally approved documents, but don't forget additionally to check your local ones. In our country, we also have such documents. We use international clinical practice guidelines, which I already show for you, and additionally our local. The question which surprisingly caused a lot of issues when we ask our students about normal values of blood pressure. Here you may see the grades of hypertension, which was published in many documents, but still some doctors and students don't know the exact values of the normal blood pressure and grades of hypertension. So the optimal blood pressure is systolic BP less than 120 and diastolic less than 80 millimeters. Normal blood pressure 120-129, and for diastolic, accordingly 80-84. High normal, which may be considered as pre-hypertension, not hypertension itself, but a condition of pre-disease. High normal blood pressure is 130-139, and diastolic blood pressure 85-89. If our patient has blood pressure higher than 140 for systolic or 90 for diastolic, we may say about arterial hypertension. And according to systolic or diastolic blood pressure, we may diagnose different grades of arterial hypertension. The first one, first grade or mild hypertension, systolic 140-159, and or diastolic blood pressure 90-99. Second, moderate hypertension 160-179, and diastolic 100-109. And severe arterial hypertension more than 180 for systolic, and or diastolic blood pressure higher than 110. When you diagnose the grades of arterial hypertension, you should use most severe values. So if your patient has systolic blood pressure for second grade, but diastolic blood pressure for severe grade, you should diagnose third grade of arterial hypertension. And sometimes we have isolated systolic arterial hypertension. It's a quite rare cases when systolic blood pressure higher than 140 and diastolic blood pressure less than 90 millimeters. The modern approach for the treatment of different nosologies includes the risk stratifications. Risk stratifications is approach which is based on calculation of risk factors and additionally includes risk factors and blood pressure values. We may create a table such one you see on this slide, and in the left side of this table you will see risk factors, how many risk factors our patient has, and on the first row you see the grades of arterial hypertension we already discussed a minute ago when we worked with previous slide. So if our patient has no risk factors and first grade of arterial hypertension, the risk is considered as low. But if our patient has second grade of hypertension, risk considered moderate, and severe arterial hypertension and no risk factors, high risk. Next row, one or two risk factors, the same approach. You see how risk changed in this row. And when we define the risk, we should clarify why some risk is considered as low, other is moderate and or high risk. What does it mean, high risk or low risk? So absolute, this risk is absolute risk of development of fatal and non-fatal cardiovascular event within next 10 years of patient's life. If we say that risk is low, that means that frequency of fatal events and non-fatal events within next 10 years is less than 15%. Moderate risk 15-20%, high risk 20-30%, and very high risk more than 30%. So we may say that more than 30 patients in very high risk groups will have fatal or non-fatal cardiovascular event, myocardial infarction, stroke, and so on. Which risk factors are considered as important for arterial hypertension? First of all, it's a male sex. It's an old age, men older than 55 and women older than 65. Smoking, dyslipidemia, family predisposition, obesity, impaired glucose tolerance, high fasting glucose level. Target organ damage. If we look on this slide once again, you will see what does it mean. Target organ damage, including asymptomatic injury, left ventricular hypertrophy, proteinuria, elevated blood creatinine, atherosclerosis of carotid, iliac, or femoral arteries, aortic atherosclerosis. And also in arterial hypertension, we have so named associated clinical conditions. So complications, if you want, of arterial hypertension. So arterial hypertension may lead to organ damage or may have associated clinical conditions such as stroke, transitory ischemic attack, myocardial infarction, angina, diabetic nephropathy, dissecting aortic aneurysm, retinopathy, and so on. And diabetes mellitus is also very important risk factors of fatal and non-fatal events, cardiovascular events. Management of hypertension depends on risk stratification. We already discussed how we calculate the risk and what does this risk mean. And according to this risk-based approach, we have recommendations, and we may make recommendations for our patient with arterial hypertension. The same, absolutely the same table as we already seen on risk slide with risk. But here we have recommendations for our patient according to level of risk. Low risk, moderate to high, high, and very high risk. So if our patient has low risk, it may be important to recommend lifestyle changes for several months, or in case it's not enough, we may prescribe one antihypertensive drug targeting blood pressure less than 140/90 for low-risk patients. For patients with moderate risk, again, lifestyle changes should be recommended, and addition of blood pressure drugs. For patients with high risk, lifestyle changes should be recommended, but it may be not enough, so immediate prescription of antihypertensive drug is obligatory. So if in case of low risk, we use drugs only after inefficiency of lifestyle changes. So in this case, we combine lifestyle changes and PP drugs. And in patients with very high risk, again, lifestyle changes should be recommended. As you see, lifestyle changes is very effective intervention for patients with arterial hypertension. It's obligatory intervention, which does not depend on risk value. It should be recommended for all patients. So to cease smoking, to increase physical activity, and so on. But in patients with very high risk, so lifestyle changes should be obligatory again, and prescription of blood pressure lowering drugs. What is our target in case of arterial hypertension treatment? Here you see the blood pressure goals in hypertensive patients, and patient low or moderate cardiovascular risk, patient with diabetes, patient with stroke or coronary heart disease in anamnesis, target value is for systolic blood pressure less than 140 millimeters. If our patient is relatively young, less than 80 years old, and initial systolic blood pressure higher than 160 millimeters, our target may be a bit higher. So we should decrease blood pressure to the diapason from 140 to 150 millimeters. For patients who in age less than 80 years old, without high initial blood pressure, the recommendation is the same as for first group of patients. If our patient is more than 80 years old age and has high initial level of blood pressure, again, we may decrease blood pressure to 140, 150 range of systolic blood pressure. And for diastolic blood pressure, usually general recommendation to decrease blood pressure less than 90 millimeters. For patients with diabetes mellitus should be decreased less than 85 millimeters. Which lifestyle modification should be made to influence on blood pressure? First of all, and all of these recommendations has level of evidence A, so we may be absolutely sure that this modification works and cause real effect. It's to restrict salt consumption to 5-6 grams per day only. Moderation of alcohol consumption to no more than 20-30 grams of ethanol per day for male patient and no more than 10-20 grams for female. Hypertensive patients also should be advised to eat more vegetables, to decrease fat products, to increase dietary and soluble fiber consumption, whole grains, plant proteins, and other meal with reduced amount of saturated fat and cholesterol should be recommended for them. Reduction of body weight, it's also quite important intervention. So our goal is body mass index of about 25 kilograms per square meter and waist circumference for men 102 centimeters and for women 88 centimeters. So decrease of body weight. And of course, smoking cessation. So we should recommend patients to leave smoking if they still smoke. And we may advise to participate at least in at least 30 minutes of moderate intensity dynamic aerobic exercises. So to make cardio, maybe walking, jogging, cycling, swimming, and without holidays, so 5-7 days per week, our patients should take this dynamic aerobic exercise. Okay, let's return to physiology, pathophysiology of blood pressure. And as you remember, 3 main factors which determine BP value in our organism. The first one is circulating blood volume, total peripheral vascular resistance, the second one, and cardiac output. So every antihypertensive drug which we may use in our practice should influence on 1 or 2 or all 3 factors. So when we decrease blood volume, when we decrease vascular resistance, and when we decrease cardiac output, we will decrease the blood pressure. Diuretics decrease circulating blood volume, so decrease the blood pressure. AC inhibitors decrease total peripheral vascular resistance and decrease blood pressure. Beta adrenal blockers decrease cardiac output and decrease total peripheral vascular resistance. So influence on two factors and decrease blood pressure again. So it's a direct link between increase or decrease of these factors and blood pressure. And vice versa. When we need to increase blood pressure, we should increase one of these factors. So we may increase cardiac output, blood pressure will be increased too. We may increase circulating blood volume with plasma expanders or intravenous solutions, and we will increase blood pressure again. So decrease one of this factor or more than one, and you will decrease blood pressure. Increase one of them or all of them, and you will increase blood pressure. So which groups of of the drugs may be used in treatment of arterial hypertension? I hope that we already have some students, 3 students only. Okay, let's continue. We divide all antihypertensive drugs on 2 big groups, first line and second line medicinal products. The first line group include thiazide and thiazide-like diuretics, NC inhibitors, angiotensin receptor blockers or angiotensin receptor antagonists, calcium channel blockers, beta adrenal blockers, imidazoline receptor antagonists, and renin inhibitors. As you see, the last 2 groups are marked by questions. So not all of actual documents include these 2 groups. And in many documents, imidazoline receptor antagonists and renin inhibitors are considered as a second-line medicines. So all other drugs which may be used in arterial hypertension, which may decrease blood pressure, but have not all advantages of first-line medicines. And the main advantages why we consider thiazide diuretics, ACI inhibitors, calcium channel blockers, beta blockers as first line is the safety and effectiveness of this drug. So the optimal risk-benefit ratio which was calculated during clinical trials. Second-line medicines may have issues with efficacy or may have some safety problems. And the first group which we should start at is beta blockers. During general pharmacology, basic pharmacology course, you study beta adrenal blockers in details, and I just want to remind you that classification of beta blockers includes selective and non-selective beta adrenal blocker. So we have a few types of beta adrenal receptors, beta 1, beta 2, and beta 3. And in case of cardioselective drugs, we mean drugs which block beta 1 adrenal receptor. If adrenal blocker blocks beta 1 and beta 2, we say about non-selective activity. As you remember, beta 2 receptors may be found in bronchi, in the smooth muscle of bronchi, may be found in skeletal muscles, may be found in uterus. And influence on this blockade of these receptors in these organs may not be necessary, may be dangerous for our patient, may cause bronchoconstriction and so on. That's why it's recommended to use selective drugs, selective beta 1 adrenal blockers such as metoprolol, bisoprolol, and intrinsic sympathomimetic activity. It's not clinically significant property, and now it does not influence on our choice of beta adrenal blocker. Also, we have some beta adrenal blockers with additional properties such as ebivalol, which may be used as weak nitric oxide donors, so it's a weak nitrate. But again, we have not good evidence that selective beta adrenal blockers with such additional property significantly improve effect of treatment and prevent mortality and complications. Mechanism of action for beta adrenal blockers includes two factors: reduce cardiac output and decrease peripheral vessels resistance. Side effects most frequent are bradycardia, hypertension, withdrawal syndrome. For case of non-selective drugs use, hyperglycemia, low extremity edema, erectile dysfunction. Of course, you have heard about atenolol problem. Atenolol is cardioselective beta-1 adrenal blocker. And 15 years ago, it was shown in one of the meta-analyses that atenolol increased the risk of stroke in patients who takes these drugs. This effect was found for all beta adrenal blockers, but then analysis of subgroup in this trials found that only atenolol was responsible for such effect, so increase of stroke and overall mortality. So now atenolol is recommended to be excluded from the recommendations, from the list of prescriptions, but other adrenal blockers are still first-line drugs for our patient with hypertension. Diuretics is second and the most cheap group of drugs which we may recommend for our patient with arterial hypertension. They are good for long-term treatment of hypertension. I mean thiazide and thiazide-like diuretics. Other diuretics should be used only in case of complications, such as loop diuretics in patients with edema of lower extremities, in patients with heart failure, and so on, but should not be used in patients with arterial hypertension who have not such conditions, who has not complications, edematous complications of arterial hypertension. Thiazide additionally has a positive effect for women in postmenopausal period, because the only diuretics group which allow to save calcium and prevent fractures, which are very important problem for these patients. Thiazide-like diuretics, in comparison with thiazide, classic thiazide diuretic, decrease risk of diabetes mellitus development. So in patients with risk factors, in patients with glucose intolerance and so on, should be used before thiazides. And additionally, the last data about thiazide diuretics, they increase the risk of non-melanoma skin cancer in patients with arterial hypertension, other conditions which need diuretic treatment. And it's quite important. It's dose-dependent and duration-dependent effect. So it should be recommended for our patient to protect their skin from ultraviolet, from the direct sun rays, if they take thiazide diuretics, but not thiazide-like. What's new in guidelines? So diuretics remain the cornerstone of hypertension therapy, and one of the most important reasons they are accessible for patients. They are not expensive. Chlorthalidone and indapamide are still not more preferable than traditional thiazide diuretics. Spironolactone and its alternatives, so potassium sparing diuretics, aldosterone antagonists such as eplerenone, may be used as additional therapy in patients with arterial hypertension and chronic heart failure. The third group of first-line therapy is calcium channel blockers. And again, I want to remind you classification of one of the classifications of calcium channel blockers, phenylalkylamines, benzodiazepines, and dihydropyridine derivatives, three generations of dihydropyridine derivatives, which may be used now. And accordingly to types of channel, calcium channel, effects of these groups may be different. And here you see in which cases calcium channel blockers of different groups may be recommended. So for coronary heart disease, for example, we should use benzodiazepines or dihydropyridine derivatives of third generation. But for arrhythmia treatments, phenylalkylamines are still the first line treatment. In case of hypertension, phenylalkylamines, benzodiazepines will not be very effective, but first, second, and of course third generation amlodipine quite effective and should be recommended for many patients. Other advantages of calcium channel blockers: they do not affect lipid and carbohydrate metabolism that may be used with drugs for replacement hormone therapy. Quite safe during pregnancy, more effective in older age groups, may be combined with NSAIDs, and does not significantly influence on uric acid levels, hyperuricemia in patients with gout, and sometimes the patient may have asymptomatic hyperuricemia, which by some authors now is considered as one of the metabolic syndrome, additional metabolic syndrome component. So not only diabetes mellitus, obesity, arterial hypertension, but additionally hyperuricemia. And hyperuricemia should be diagnosed, and recommendations to how to modify diet of patients should be made. Calcium channel blockers, accordingly to their chemical structure, may cause different effects and different side effects. Most frequent one is edema of lower extremities in case of dihydropyridine derivatives, but you should not forget about more severe adverse reactions such as arrhythmic disorders, such as constipation, especially for phenylalkylamine derivatives, headache, hypertension. And calcium channel blockers still present in all guidelines for treatment of arterial hypertension. You will find them in American, European, local guidelines. And you may read in some articles that it was discussed the risk of coronary events for these drugs, especially for dihydropyridine derivatives. But this elevation of risk, which was previously suggested, was not proved in population studies. ACE inhibitors, the group number 4 in our list, we may use chemical classification according to their chemical structure: sulfogidril containing, decarboxyl containing, phosphorus containing. But clinically, this classification is not relevant. More important for us to know are they need do they need metabolism and deliver and time of onset of their effects. And such classification was proposed by Lionel Opie, famous cardiologist, and you may find his books. You might buy his book about heart and drugs for heart, where you will read a very interesting story about all groups we discussed today, including ACE inhibitors. ACE inhibitors, by the way, were found, first ACE inhibitors were found in snake venom, and the bite of this Brazilian snake jacaraca caused a rapid decrease in blood pressure, and the scientists started to investigate this venom, the components of this venom, and found the first ACE inhibitors. So let's return to the classification of ACE inhibitors, and on the table in the lower part of our slide, you will see three generations, and their characteristic. The first one is hydrophilic drugs, which are not metabolized by liver, with short duration of action, but very fast onset of effect, such as captopril. Second generation need metabolism in liver. They are lipophilic drugs and cannot cause such fast effect because they are lipophilic and need metabolism. Enalapril, fosinapril, ramipril, and other drugs. And the third generation are active metabolite of second generation drugs, which cause very fast but very short effect. Such drug as enalaprilat. Enalaprilat is active metabolite of enalapril. All second generation drugs in our liver are converted in active metabolites. So ACE inhibitors are prodrugs. Classic scheme of ACE inhibitors action. You see that ACE block conversion of angiotensin 1 to angiotensin 2. But we also has additional routes, additional reactions which allow to synthesize angiotensin 2 from angiotensin 1 or angiotensin gene by local hymases way, non-ACE pathways, so name it. And in this case, in case of ACE inhibitors prescription, we cannot completely block the formation of AT2. That's why next group, which was included as a first-line group and was found after ACE inhibitors, angiotensin receptor blockers, which block AT1 receptors for angiotensin 2. They are a bit more effective because in this case it does not influence, and amount of AT2 does not play a very important role in the fact. Okay, let's return to the ACE inhibitors. Advantages: decreased risk of diabetes mellitus type 2 development. ACE inhibitors do not impair metabolic profile and capable of insulin resistance reduction. They may reverse left ventricular hypertrophy in patients with arterial hypertension, and now they are not very expensive. Adverse drug reactions: hypertension, hyperkalemia, don't forget about it, especially when you try to combine ACE inhibitors and potassium sparing diuretics. Dry cough. Every second patient has dry cough. of different intensity. It may be light cough, it may be very severe cough, proteinuria, angioedema, which also caused by bradykinin-dependent mechanism, like cough. So it's not a real allergic angioedema. It's angioedema caused by bradykinin. And you see that for AC inhibitors, the frequency of angioedema is quite high in comparison with other groups. Taste disorders, dysgeusias, skin rash, dyspepsia, and teratogenic effects. They should not be used in pregnant patients. 82 receptor blockers, losartan, valsartan, and others mentioned on this slide. They have some advantages. First of all, they do not influence on bradykinin level. So for them, the risk of cough, risk of angioedema is minimal. But influence on left ventricle hypertrophy not so good as for AC inhibitors. Additionally, they cannot cause a first dose hypertension, which may be noticed when we used AC inhibitors. What is more effective, AC inhibitors or angiotensin receptor blockers? Very popular questions, but at the moment there are no any evidence of superiority of one class over the other. So both drugs groups seems to influence endpoints equally, and in this case, does not matter which drug you use, but decrease of blood pressure play the important role. Double block of renin-angiotensin system, which was popular 10 years ago, now is not recommended due to negative risk-benefit ratio. The risk of kidney injury, the risk of stroke in patients who received both drugs, ACE inhibitors and angiotensin receptor blockers, significantly higher in comparison with monotherapy of one of this group. And the last group, which influence on renin-angiotensin system, is renin inhibitors. This group was developed more than 20 years ago, but the first drug, aliskiren, was registered not so long time ago. Now we cannot consider renin inhibitors as the first-line therapy because they have not any additional effect in antihypertensive activity, which is equal to diuretics, ACE inhibitors. Combination of renin inhibitors with ACE inhibitors or with sartans are not safe. So again, the risk of hypertension, hyperemia, kidney injury significantly increases. So it's the same double blockade of renin-angiotensin system. No positive effect on hospitalization and mortality rate was found in comparison with the standard therapy, and we may use renin inhibitors. In some patients, we need them when we have contraindications. Some contraindications for first-line antihypertensive drugs, but all of these great ratings for renin inhibitors, unfortunately, was not proven. It's one more group, but which did not make a revolution in treatment of arterial hypertension. And imidazoline receptor agonist, moxanidine, which stimulate imdazoline receptors in the lower brainstem region. So central type of action. This drug is actively used in our country in patients with crises, but it's not a good practice because in patients, old patients 70 years old and more than, it may be very dangerous, rapid decrease of blood pressure. But moxanidine is included in clinical practice guideline for metabolic syndrome treatment. It positively influence on carbohydrate and lipid metabolism, may decrease blood level of glucose, leptin, triglycerides, and decrease body mass index. So it may be important for patients with metabolic syndrome. Which group of the mentioned first-line therapy groups is more preferable than others? And the answer is the same. No one group, because the major mechanism of the benefits of antihypertensive therapy is lowering of blood pressure. It does not matter which drug you use to decrease blood pressure. The effects of co-specific outcomes of the various agents are similar or differ by only a minor degree. We have not significant advantages or disadvantages of one of the mentioned groups. The types of outcome in a given patient is unpredictable, and all classes of antihypertensive agents have their advantages and contraindications, and we should take them into account. So one of the principles of clinical pharmacology is individual approach, and in this case, this principle is may be used as example. So therapy should be individualized. Combination therapy, very often used in patients with arterial hypertension, and here you see the recommended algorithm how to combine and how to define the need for combinations. We should choose. We should calculate cardiovascular risk. We should calculate the grade of arterial hypertension, and in case our patient receive single agent, we may, in case of the lack of effect, to switch to different ages or to use combinations of the drugs. If our patient already takes the combination of drug, we may increase the dose, we may change one drug in combination, or sometimes in case of not effective treatment with two drugs, we may add a third drug. Possible combinations of first-line therapy groups. Green lines mentioned rational combination, so ACE inhibitors and thiazide diuretics, ACE inhibitors and calcium channel antagonists, thiazide diuretics and calcium channel antagonists are good combinations, effective. Less recommended and less tested combination, which has some limitations, are marked by dotted green lines. Even less combination possible combination, but less well tested, less effective, and red line the only red line on this slide between AC inhibitors and sartans means not a recommended combination. And why this combination is not recommended, we already discussed, because increase the risk of kidney injury, increase the risk of hypotension. And ABCD algorithm, which also may be used. It was proposed more than 10 years ago by Royal Cardiology Society in UK. According to race and according to the age of patient with arterial hypertension, we should choose monotherapy or combination of first-line therapy drugs. If our patient is less than 55 years old and not African patient, we should prescribe monotherapy, A or B in case of first grade, C or D in case of first grade, but if our patient is older or African. Mild arterial hypertension, monotherapy with one drug. Second step, second grade of arterial hypertension, moderate arterial hypertension, combinations of two drugs, A or B plus C or D. So A, C, A, D, B, C, B, D. 4 possible combinations. And severe arterial hypertension, 3 drugs should be used, A plus C plus D. And in case of resistant hypertension, we may add either alpha blocker or spironolactone or other diuretic for this patient. So what is A, B, C, and D? You may see in the legend. A is inhibitor or sartan, B beta blocker, C calcium channel blocker, and D diuretic. Fixed dose combinations also very popular among patients because it's quite comfortable to take one drug with 2 components or 3 components than to take 3 different tablets, pills. Fixed dose combination allow us to eliminate possibility of rational drug combinations. So it's always rational combinations of drugs. Simply prescription and dose titration. Drugs may potentiate antihypertensive effects of each other. Fixed dose combinations improve compliance of patient and responders to therapy accordingly. Decrease the rate of adverse drug reaction development. It may be due to low doses of components and usual neutralization of adverse drug reactions. And decrease the cost of treatment, of course. So it's also very important. Compliance of patients to therapy is quite poor, and we use everything to improve it. Here you see the results of follow-up of patients after first prescription of drugs, antihypertensive drugs. How many patients continue the therapy which was recommended on the first visit? First year, men and women, 100%. But then you see how this amount decreases. Second year, 60%. Third year, about 50%, less. And after 10 years of treatment, only 40% of patients with arterial hypertension still follow up doctor's recommendation on treatment of arterial hypertension. That's why it's very, very important to check your patient compliance yeah, to work with patient, to communicate with patient, and uh, make uh, make changes in therapy if it's important. That is all for current topic for arterial hypertension. I want to say thank you for students who still with us. Only two students now online. Uh, Keep healthy, uh, and we will continue our lectures in 2 weeks. Thank you again, and bye bye.